Hello, it's Dmitry again. Today we'll be going back to the Blueprints Psychiatry textbook, now on Chapter 4, Personality Disorders. Now again, this is the 5th edition of the Blueprints Psychiatry textbook. There's also a more recent 6th edition as well, which is a little bit more updated. The content's relatively similar, but the organization of the material and some of the content is somewhat different. Nevertheless, we'll be going to the chapter on personality disorders today. So Chapter 4. Personality disorders are coded on the Axis 2 in the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, DSM-4. And for reference, DSM-4 has been ameliorated or updated with the DSM-5. 10 types of personality disorders are grouped into clusters based on similar overall characteristics. There are 3 recognized personality disorder clusters: odd and eccentric, dramatic and emotional, and anxious and fearful. DSM-4 general diagnostic criteria for personality disorders are outlined in the Table 4.2. Criteria for individual personality disorders are discussed below. Personality disorders frequently overlap in symptoms. Table 4.3 indicates the primary ego defense mechanisms. See Chapter 17 on psychological theory for discussion of ego defense mechanisms. Found in a subset of personality disorders, an individual may use multiple defense mechanisms, however. Neural basis. Earlier psychoanalytic theories focused on the role of infantile development in personality disorders. More recent scientifically grounded theories have emphasized the role of neurobiology and evolutionary psychology in personality disorders. Current evidence supports an interaction of genetics and environment in producing personality. In particular, emerging theories support the role of physical and emotional trauma in producing borderline personality disorder in vulnerable individuals. Brain imaging studies support the presence of altered brain structure and function in some personality disorders. Although the DSM-4 criteria for personality disorders are categorical, much contemporary research approaches them as dimensional. Some theorists, like here Lara and Ekiskal, 2006, consider fear and anger traits as the core dysregulated emotions in personality disorders. Others, that is to say, Goodman et al. 2004, embrace more dimensions of personality structure, including affective instability, impulsivity, aggression, anxiety, and cognitive factors. As a useful mnemonic, it is helpful to consider the origins of particular symptoms such as fear, anger, anxiety, and aggression as having their roots in ancient neural structures related to the limbic system, especially the amygdala, hippocampus, and cingulate gyrus. And the monoamine neurotransmitters, serotonin, dopamine, and norepinephrine, with the expression of those symptoms modulated by more recently evolved brain regions such as the neocortex and the neurotransmitters such as the gamma-aminobutyric acid and glutamate. And so what they're saying is that, of course, they're kind of presenting in the context of evolutionary psychology. Oh, these things developed over the course of many, many generations, across different species and of development, that kind of thing. That's kind of the way they're couching it, essentially. But the important thing to say here is that they're talking about, let's go back to it, is the origins of particular symptoms such as fear, anger, anxiety, and aggression have their roots in ancient neural structures related to the limbic system. So basically, these basal emotions, fear, anger, anxiety, aggression, these are rooted in things that are like sub-rational in the mind. They're not necessarily, I mean, you can have a rational concept of being afraid of dying, for example. But really the root passion for why you have an emotional reaction related to fear, aggression, anxiety, so anger, so forth, there's a basal passion that exists in the person. And that sort of neural framework is going to be shared with non-human animals as well. Really what helps distinguish mankind from a lot of the more, people say primitive, but really other species of animal which are not human, they're not rational, is that we have this much more complicated system in the neocortex, as they describe here, and in the, I would say the cerebral cortex writ large, right? That is going to be involved in this more complicated systems of thought that are rational, where you can rationally think about, this, that, and the other, and not necessarily be bound up with these sort of sub-rational emotional dispositions, which humans do share with other animals. Like, basically human beings have basal passions like other animals. They want to eat, they want to sleep, they want to be able to reproduce, they want to be able to avoid predators, avoid things that can harm them, etc. They don't want to be in pain, etc. They want to do these kinds of things. And so there's a sort of this very root, very basal, very sub-rational qualities to human beings that kind of motivate them to do these things. And of course, the problem is that these are sub-rational, and so they can lead to some problems potentially as well. Cluster A, odd and eccentric. Paranoid personality disorder. People with paranoid personality disorder are distrustful, suspicious, and anticipate harm and betrayal. Epidemiology. Paranoid personality disorder has a lifetime prevalence of 0.5% to 2.5% of the general population. Relatives of patients with chronic schizophrenia and patients with persecutory delusional disorders show an increased prevalence of paranoid personality disorder. Table 4.1, classification of personality disorders. So we have cluster A, cluster B, and cluster C. So cluster A, these are the odd and eccentric. Cluster B is the dramatic and emotional, and cluster C is the anxious and fearful. I've heard it as weird, wild, and worried. I don't know if that's considered the most totally accurate or, not with some baggage to it or whatever, but the cluster A are the quote-unquote weird group, B is the quote-unquote wild group, and C is quote-unquote the worried group. So let's talk about cluster A, the odd and eccentric type. You have paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder. Cluster B, that's the wild category, the antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Now, cluster C, which is the worried group, is the avoidant personality disorder, the dependent personality disorder, and the obsessive compulsive personality disorder. Okay, so etiology. We're talking about before, what specifically? We're talking about paranoid personality disorder. Okay, so cluster A stuff. It says etiology, environmental precursors are unclear. Family studies suggest a link to delusional disorder, paranoid type. There appears to be a small increase in prevalence among relatives of individuals with schizophrenia. Clinical manifestations. History and mental status examination. People with paranoid personality disorder are distrustful, suspicious, and see the world as malevolent. They anticipate harm, betrayal, and deception. Not surprisingly, they are not forthcoming about themselves. They require emotional distance. Table 4.2, diagnostic criteria for personality disorders. Patients with personality disorders evidence an enduring pattern of inner experience and behavior established by adolescence or early adulthood that 1. Deviates markedly from cultural expectations, 2. Is inflexible and personally and socially pervasive, 3. Causes distress or social or work impairment, 4. Is a stable pattern of experience and behavior of long duration. They stay unstable, stably unstable. They're consistently unstable. Number 5, they cannot be explained by another mental illness. So there's not another explanation for it that falls out personality disorders necessarily. And there is like some overlapping symptoms with things that are non-personality disorders for reference. As you can imagine with things like schizoid or schizotypal, you can think there might be some issues where there might be overlapping with other kind of stuff. But it is its own thing. It is not caused by substance use or medical condition. So it's not because they're on drugs or something. It's some sort of, it is its own thing. Note, individuals with personality disorders usually maintain intact reality testing, but they may have transient psychotic symptoms when stressed by real or imagined loss or frustration. Personality disorders are different from personality traits that are typically adaptive, culturally acceptable, and do not cause significant distress or impairment. That's the important difference, is that it's not something that they're a particular personality. Oh, this guy's more talkative, he's more reclusive, whatever it might be. These people have a personality disorder where they have a maladaptive personality. It doesn't function correctly. It's causing problems for them in their life. Reproduce with permission from, okay, yeah, so that's just a little reference or a little attribution. Table 4.3, primary ego defense mechanisms in some personality disorders. Disorder and the defense. So we have the disorder, paranoid personality disorder. The defense is projection. In schizoid personality disorder, the defense is fantasy. In borderline personality disorder, you have splitting or acting out. Splitting, by the way, is saying this person's either completely evil and they're awful and they're terrible, or they're completely good and they're wonderful and they're angelic and they do nothing wrong. Next one is histrionic personality disorder. The defense is dissociation. And then we have the obsessive compulsive personality disorder, and the defense is isolation. Differential diagnosis. The key distinction is to separate paranoia associated with psychotic disorders from paranoid personality disorder, especially because paranoia is associated with psychotic disorders is generally responsive to antipsychotic medications. Schizoid personality disorder. Individuals with schizoid personality disorder are emotionally detached and prefer to be left alone. Epidemiology. Estimates of lifetime prevalence range as high as 7.5% of the general population, but because people with schizoid personality disorder are avoidant of others, they are not commonly seen in clinical practice. Well, that's pretty high. 7.5% is pretty high. Etiology. There is some evidence to suggest that increased prevalence of schizoid personality disorder in relatives of persons with schizophrenia or schizotypal personality disorder. So there is some, maybe some sort of genetic basis that's causing these things that are interconnected. Clinical manifestations. History and mental status examination. These people are loners. They are aloof and detached and have profound difficulty experiencing or expressing emotion. Although they prefer to be left alone and generally do not seek human relationships, they may maintain an important bond with a family member. So again, we're talking here about schizoid personality disorder, which is different from schizotypal, which is going to be talked about in a bit. So schizoid, they're kind of loners. They might have a close friend, but that's about it. They don't really want to be around a lot of people. So here's a diagram here, figure 4.1. Limbic system neuroanatomy. Major limbic system structures involved in mediating many normal functions and those dysregulated in psychiatric disorders. The amygdala, hippocampal formation, cingulate gyrus, and the interconnected structures may be important in the many components of personality disorders, especially those characterized by anxiety/fear and anger/aggression. So you can see the cingulate gyrus, the corpus callosum, the body of the fornix, stria medullaris phalanmi, stria terminalis, amygdala, hippocampus, mammillary body, the olfactory tract. Differential diagnosis. Schizoid personality disorder can be distinguished from avoidant personality disorder, see later, and social phobia by the fact that schizoid individuals do not desire relationships. That's important. The schizoids do not want the relationships to be the case. The avoidant and socially phobic persons desire and may seek relationships, but their anxiety handicaps their capacity to achieve relatedness. Schizophrenia, autistic disorder, and Asperger's disorders, a less severe variant of autism, are also differential diagnostic conditions. Okay, but just remember that schizoid, they don't want to be around people. It's not that they're afraid of people. It's not that they want to have friends, but they're anxious about it. No, they just don't want to have a lot of friends. Okay, that's the way schizoid personality is. What about schizotypal? Schizotypal is a little bit different, right? Schizotypal personality disorder. Soul cluster A, by the way. Individuals with schizotypal personality disorder have odd thoughts, affects, perceptions, and beliefs. Epidemiology. Lifetime prevalence is 3% of the general population. Etiology. Studies demonstrate the interfamilial aggregation of this disorder, especially among first-degree relatives of individuals with schizophrenia. So again, there might be some underlying genetic basis or risk factors that can lead to it that overlap with schizophrenia. Clinical manifestations. History and mental status examination, schizotypal personality disorder is best thought of as, as similar to schizophrenia, but less severe and without sustained psychotic symptoms. People with this disorder have few relationships and demonstrate oddities of thought, affect, perception, and belief. Many are highly distrustful and often paranoid, which results in a very constricted social world. The lifetime suicide rate among this population is 10%. Pretty high. Differential diagnosis: schizophrenia, delusional disorder, and mood disorder with psychosis are the major differential diagnoses. So you have to keep this in mind. If you see somebody with schizoid person or schizotypal, what are we on here? We're on schizotypal. Yeah, we're schizotypal. You want to make sure that you can rule out schizophrenia, delusional disorder, and mood disorders with psychosis as well. Right. Just be aware of the actual different things that would qualify and see which one is and which one it isn't. Cluster B, dramatic. So now we're talking about cluster B. Those are the wild. So we said cluster A is weird, cluster B is wild, and cluster C is worried. So cluster B, wild, dramatic, and emotional. So what is included here? Antisocial personality disorder, also called sociopathy. Well, no. Well, antisocial personality disorder is sociopathy. Yeah. So yeah, they're sociopaths. Individuals with antisocial personality disorder, ASP, repetitively disregard the rules of and laws of society and rarely experience remorse for their actions. Epidemiology. ASP, against sociopathy, is present in 3% of men and 1% of women. About half have been arrested, and about half of those in prison have ASP. That's pretty high. Half of them? Wow. Etiology. ASP is more common among first-degree relatives of those diagnosed with ASP. In families of an individual with ASP, men show higher rates of ASP and substance abuse, whereas women have higher rates of somatization disorder. Oh, that's weird. So there might be some underlying genetic basis that connects the sociopathy and somatization disorder, and this is another thing too, because if think about how, as a human being, it's not like, oh, this one gene causes this one thing, this other gene causes this one thing, and this one environmental factor causes this one thing. Like, it's very granular. It's not. It's very messy, because life is complicated, And so apparently whatever basic baseline genes, which when they express themselves in a man, they might cause them to have sociopathy. They might cause them to have antisocial personality disorder. But they might cause a woman, for example, who has a different hormone profile and they have an extra X chromosome and no Y chromosome to be found. They will have, maybe they might have somatization disorder, right? So it might express itself differently based on the other kinds of genetic, hormonal, and potentially some degree social effects that are influencing who they are as a person. A harsh, violent, and criminal environment also predisposes people to this disorder. Again, be aware of the fact that there could be a little bit of a chicken and the egg issue with this, because a person, for example, if your dad is a sociopath, for example, it's true that your dad might cause you to be in a very hostile environment that can cause you to be predisposed from environmental reasons, but it's also true that your dad is passing on those genes to you, which might make you more likely to be like that. So it's kind of a difficult thing to kind of parse out, Be aware of that. Clinical manifestations. History and mental status examination. Individuals with ASP display either a flagrant or well-concealed disregard for the rules and laws of society. They are exploitative, lie frequently, endanger others, are impulsive and aggressive, and rarely experience remorse for the harm they cause to others. Alcoholism is a frequently associated finding in this population. Many individuals with ASP are indicted or jailed for their actions. Their lifetime suicide rate is 5%. Differential diagnosis would be bipolar disorder, and substance abuse disorder can prompt antisocial behaviors during the acute illness, which remit when the disorder is controlled. The antisocial behavior of individuals with ASP, conversely, is not state dependent. What about borderline personality disorder? Individuals with borderline personality disorder suffer from instability in relationships, self-image, affect, and impulse control. Epidemiology for borderline personality disorder. I want to say BPD, but I know there's different things that use different acronyms, so I don't want to necessarily throw those things out there per se. Epidemiology for borderline personality disorder, lifetime prevalence is 1% to 2% of the general population. Etiology. Borderline personality disorder is about 5 times as common among first-degree relatives of borderline patients. In addition, this disorder shows increased rates in families of alcoholics and families of individuals with ASP, as well as in families with mood disorders. Females with borderline personality disorder frequently have suffered from sexual or physical abuse or both. So again, there might be some genes that are underlying multiple different disorders. Again, they might express themselves differently because of their interaction with not only the environment, but also other kinds of genes that might be expressed in that person. So again, it's complicated, it's messy. And again, obviously you can talk about the environmental situation. Maybe there's some genetic disposition, but there might also be some environmental considerations, like maybe they're abused as a kid, sexually or otherwise. Clinical manifestations. History and mental status examination. Individuals with borderline personality disorder suffer from a legion of symptoms. Their relationships are infused with anger, fear of abandonment, and shifting idealization and devaluation. Their self-image is inchoate. I'm sorry. Pardon my my ignorance. So inchoate. Yeah, inchoate is an adjective that means just beginning to form. Okay. Okay, inchoate. Their self-image is inchoate, fragmented, and unstable with consequent unpredictable changes in relationships, goals, and values. They are affectively unstable and reactive, with anger, depression, and panic prominent. Their impulsiveness can result in many unsafe behaviors, including drug use, promiscuity, gambling, and other risk-taking behavior. Their self-destructive urges result in frequent suicidal and parasuicidal behavior, such as superficial cutting or burning or non-fatal overdoses in which the intent is not lethal. They also demonstrate brief paranoia and dissociative symptoms. Suicide attempts can be frequent before the age of 30, and suicide rates approach 10% over a lifetime. The principal intrapsychic defenses such as individuals use are primitive, with gross denial, distortion, projection, and splitting prominent. Patients may exhibit a broad range of comorbid illnesses, including substance abuse, mood disorders, and eating disorders. Differential diagnosis, mood disorders, and behavioral changes are resulting from active substance abuse are the principal differential diagnostic considerations. The diagnostic clues are unstable relationships, unstable self-image, unstable affect, and unstable or impulsive behaviors. Histrionic personality disorder. Individuals with histrionic personality disorder have excessive superficial emotionality and a powerful need for attention. Epidemiology. Lifetime prevalence is 2% to 3% of the general population. In clinical settings, the diagnosis is most frequently applied to women, but may equally affect men in the general population. So, it seems to be more diagnosed in women, but it might also be as common in men. Etiology. There appears to be a familial link to somatization disorders and to ASP. So again, here's this other connection to ASP and somatization disorder through the familial linkages. Is that because of a shared family environment that creates these kinds of disorders? Is it because of a genetic basis which helps predispose somebody to a disorder such as these? It's a little bit blurry, you could say. I would assume there's some genetic basis, but it's not a totalizing effect, Clinical manifestations. History and mental status examination. Individuals with histrionic personality disorder are characterized by their excessive and superficial emotionality and their profound need to be the center of attention at all times. Theatrical behavior dominates with lively and dramatic clothing, exaggerated emotional responses to seemingly insignificant events, and inappropriate flirtatious and seductive behavior. Across a wide variety of circumstances. Despite their apparent plethora of emotion, these individuals often have difficulty with intimacy, frequently believing their relationships are more intimate than they actually are. So differential diagnosis, somatization disorder is the principal differential diagnostic consideration. Okay, that's for histrionic. What about narcissistic personality disorder? Narcissistic. Individuals with narcissistic personality disorder appear arrogant and entitled but suffer from extremely low self-esteem. Epidemiology. Lifetime prevalence is estimated to be at 1% in the general population and 2% to 16% in clinical populations. Up to 50% to 75% of those with this diagnosis are men. Etiology. The etiology of this disorder is unknown. Clinical manifestations. History and mental status examination. People with narcissistic personality disorder demonstrate an apparently paradoxical combination of self-centeredness and worthlessness. Their sense of self-importance is generally extravagant, and they demand attention and admiration. Concern or empathy for others is typically absent. They often appear arrogant, exploitative, and entitled. Despite their inflated sense of self, however, below their brittle facade lies low self-esteem and intense envy of those whom they regard as more desirable, worthy, or able. Differential diagnosis. The grandiosity of narcissism can be differentiated from the grandiosity of bipolar disorder and by the presence of characteristic mood symptoms in bipolar disorder. So again, let me read that again. So the grandiosity of narcissism can be differentiated from the grandiosity of bipolar disorder by the presence of characteristic mood symptoms in bipolar disorder. So there will be mood symptoms with the bipolar disorder that will not be present necessarily in the narcissistic personality disorder. Just bear that in mind. Cluster C, anxious and fearful. So this is what we call the worried category. So again, cluster A is weird, cluster B is wild, cluster C is worried. So cluster C, this is going to include avoidant personality disorder. Individuals with this avoidant personality disorder desire relationships but avoid them because of the anxiety produced by their sense of inadequacy. Epidemiology. Lifetime prevalence is 0.5% to 1% of the general population and appears to be equally prevalent in men and women. Etiology. There are no conclusive data. The pattern of avoidance may start in infancy. Clinical manifestations. History and mental status examination. People with avoidant personality disorder experience intense feelings of inadequacy. They are painfully sensitive to criticism, so much so that they are compelled to avoid spending time with people. Their fears of rejection and humiliation are so powerful that to engage in a relationship, they seek strong guarantees of acceptance. The essence of this disorder is inadequacy, hypersensitivity to criticism, and consequent social inhibition. Differential diagnosis. The major diagnostic distinctions between avoidant personality disorder and social phobia, generalized type. Dependent personality disorder. So this is another category. This is another disease. Disease of the mind. Dependent personality disorder. Individuals with dependent personality disorder are extremely needy, relying on others for emotional support and decision making. Epidemiology. Lifetime prevalence is 15 to 20%, 2% to 3% clinically. That's pretty high. Etiology. The etiology is unknown. Okay, I'm just thinking about the actual. So they're very needy. They need support. They want support, even in decision making. Clinical manifestations. History and mental status examination. These people yearn to be cared for because of their extreme dependence on others for emotional support and decision making. They live in great and continual fear of separation from someone they depend on, hence their submissive and clinging behaviors. Differential diagnosis. People with dependent personality disorders are similar to individuals with borderline personality disorder in their desire to avoid abandonment, but do not exhibit the impulsive behavior, unstable affect, and poor self-image of borderline patients. Okay, what about obsessive compulsive personality disorder? We're still in cluster C here. These individuals are perfectionists who require a great deal of order and control. Epidemiology. The estimated prevalence is 1% in the general population. Men are diagnosed with obsessive compulsive personality disorder twice as frequently as women. Etiology. The etiology is unknown, but there may be an association with mood and anxiety disorders. Clinical manifestations. History and mental status examination. Individuals with obsessive-compulsive personality disorder are perfectionists. They require order and control in every dimension of their lives. Their attention to minutiae frequently impairs their ability to finish what they had started or to maintain sight of their goals. They are cold and rigid in relationships and make frequent moral judgments. Devotion to work often replaces intimacy. They are serious and plodding. Even recreation becomes a sober task. Differential diagnosis. Obsessive-compulsive personality disorder can be differentiated from obsessive-compulsive disorder, so OCD, based on symptom severity. Management. Because personality may have temperamental components and is developed over a lifetime of interacting with the environment, personality disorders are generally resistant to treatment. In general, psychotherapy is recommended for most personality disorders. Psychodynamically based therapies are commonly used, although they must be modified to each individual and each disorder. Cognitive behavioral and family therapies are also used to treat these disorders. Empirical studies validating the efficacy of various therapies are generally lacking. Dialectical behavioral therapy was developed specifically for the treatment of borderline personality disorder and has been validated in empirical studies. Group therapy incorporating various psychotherapeutic modalities is also used. Pharmacotherapy is widely used in personality disorders, although no specific medication has been shown to treat any specific disorder. Instead, medications are targeted at the various associated symptoms of personality disorders. For example, mood stabilizers may be used for mood instability and impulsiveness. Benzodiazepines are commonly used for anxiety, although the potential for abuse and dependence is too often overlooked. Beta blockers are also used frequently. For depression, obsessive-compulsive symptoms, and eating disturbances, selective serotonin reuptake inhibitors, that is to say SSRIs, and other antidepressants have been used successfully. Psychotic or paranoid symptoms are commonly treated with low-dose antipsychotics. So that ends the corpus, the body of our chapter. We'll go into the key points now. So key points. Personality disorders are categorized into 3 symptom clusters, A, B, and C. Personality disorders consist of an enduring pattern of experience and behavior. The disorder can produce transient psychotic symptoms during stress. Treatment is with psychotherapy and medications targeted at symptom relief. Personality disorders are resistant to treatment. Personality disorders may have genetic associations with axis 1 disorders. And something to bear in mind as well, this is the end of chapter 4 on personality disorders. And I want to say this as well. If you hear of a personality disorder, schizoid, schizotypal, histrionic, bipolar, obsessive-compulsive, antisocial, whatever it might be, think about what category does it fit best into, A, B, or C. Because you need to think about it kind of the idea like, oh, I don't know what it is. Is schizotypal A, B, or C? Well, does it weird, wild, or worried? Or are they weird? Is it kind of strange like schizotypal or schizoid? Is it wild? Is it very expressive, very dramatic? Like, let's say antisocial personality disorder is technically part of that category, or histrionic is part of that category. Or is it more like it's worried? Are they worried? Are they like obsessive compulsive? Something like that. So just bear that in mind. What fits best into that category based off those labeling? So if you enjoyed this chapter, I hope you found it useful. But if you enjoyed this, you could subscribe or smash that like button or whatever they say. I hope you have a great rest of your day. Thank you, and goodbye.